Okay, so for my patient with lateral epicondylitis, what I'm going to first do for range of motion is check her elbow extension. The reason I'm doing this is because the patient might have presented with a flexed posture because they have pain in that lateral epicondyle, so they could potentially have reduced range of motion at the elbow. So for this, what I'm going to do is put my stationary arm at the acromion process. I'm going to have my patient bring her arm down off the table as far as she can, and then without pain, and then I'm going to my axis is at the lateral epicondyle, and then my moving arm is at the radial styloid process. So she has about 180 on this elbow, and then I'll have her flip around and we'll test the other elbow, same thing. And we want her arm to be able to slightly come off so she can get that full elbow extension off the table. And here she has about 180 as well. So they're about the same on each side. Potentially the patient could have slightly reduced elbow extension on her injured arm. So for my manual muscle test, what I'm going to be doing is an extensor carpi radialis brevis manual muscle test. The reason I'm doing this is because patients with lateral epicondylitis likely have a ruptured or torn muscle there, and it causes a lot of pain at her lateral epicondyle. So for this, what I'm going to do is bring the patient's wrist into extension and radial deviation, and I'm going to try to pull her down into ulnar deviation and flexion. The patient's going to break there, so she scored about a 4 out of 5 for that one, and then we can go ahead and do it on her other arm just to make sure that this one is strong and that it isn't like that on both sides. So she stays there, so she scores a 5 out of 5 on her good arm. Okay, so my first special test to confirm that this patient has lateral epicondylitis is doing the middle finger extension test, or the Maudsley test. So what I have the patient in right now is her elbow's in flexion, her arm is pronated, and what I'm going to ask the patient to do is lift up her middle finger here, and I'm going to apply resistance down. And when I push down, the patient has pain in her lateral epicondyle because that is the main origin of all the extensor muscles, and she breaks, her finger likely breaks. And then we can do it on the other side. Go ahead and have her lift up, push down, and the patient doesn't have any pain at her lateral epicondyle. Okay, so for my last special test to confirm that this patient has positive lateral epicondylitis, I'm going to use the dynamometer pain-free grip strength. So what I would record is that this is on the second notch because that's the most common one, and then I'm going to have the patient have their elbow at 90 degrees of flexion and just try to squeeze this until they have pain, and I want them to stop when they have pain. So I'm going to go ahead and have you do that, and you can just hold it forward here. So this is her non-injured arm, so I'll have her squeeze until she can. Good. So she got to about 26 on this side, which is within the normal range, and then I'll go ahead and reset it, and I'll have her do it on her right arm or her injured arm, and I'll have her go until she feels pain. So she has reduced on this side. She's at about 20 on this side, so that makes sense. And for this, it's a good base for when we progress in her rehab. This will give us a good measurement for, we can compare it bilaterally and just compare that individual arm for progress to make sure that she is increasing in her grip strength. For my patient with the lateral epicondylitis, the range of motion test shows us that they could have potentially some pain with that extension, and likely they will have reduced extension or flexion range of motion, and it could be due to swelling. So one manual intervention that we can be doing with that is just trying to reduce the swelling, having the patient hold their arm up, manually trying to get rid of the swelling throughout their arm there, and then just trying to work on that pain reduction as well. So having them rest, ice, giving it a break, just so it doesn't help increase the pain. For the manual muscle test of the extensor carpi radialis brevis, we also just kind of want to start working on stretching that because they also likely have reduced extension range of motion. So we can work on stretching first, and then progress to having the patient strengthen their extensor carpi radialis brevis, so like doing isometric holds, and potentially progressing to wait until it doesn't produce any pain along that lateral epicondyle. For the Maudsley test, that's just showing also again that the origin of those muscles there is what's causing the irritation, so we can do some joint mobilizations as well to try to help relieve the tension on the muscles there and try to help also reduce the swelling. And then for the pain-free grip strength, that can also help progress our treatment. So when the patient is gripping, we can help start working on their grip strength. Also just showing that we need to focus on that pain first, that inflammation, reduce that with our treatment, and then progress to strengthening the grip strength. And it's just a good way to assess progress throughout our treatment program.